Well, thank you. Thanks for our sponsors. And I want to thank Adam Ryskowski. Did I say it right this time? For joining? Adam will be happy. I finally pronounced his name right. He comes on it every single time. So got a great issue tonight we're going to talk about hip arthroscopy versus conservative care for FAI syndrome. Two great people on with us from Melbourne, Australia. I'll get to them in just a moment. First, let's go to Barbara. Barb, you want to introduce yourself real quick?
Sure, thanks. I'm Barb Hoogenboom, and I hail from Grand Rapids, Michigan, and Grand Valley State University. Shout out to my Grand Valley grads. I see a few of you on there. Thanks for joining up. I will say that we're having some pretty nasty weather in Lowell, Michigan. So if I go away, it may be due to a power or internet outage. Not that I'm not interested, Amir. Not that I'm not interested. Thank you for showing up and for being here.
All right, Philly.
Hey everybody, Phil Page, Fran Yu, and Baton Rouge. Of course, thanks to Ashley for putting all this together, the journal, and to our sponsors. And welcome to our friends tomorrow
That's right.
from down under. And go Tigers. We are 0-0 in the top of the second. So I will be watching it. I don't have bad weather, but if I go a little crazy, it's because the Tigers scored.
There you go. Mike, you want to introduce yourself since you're on with us?
Yeah, I'm Mike Voigt, and I'm not the one who looks like I'm sitting in a car or something like this. I'm not, unlike Barb, I have beautiful weather here, blue sky, sunshine, and for some reason I've lost all internet. I've lost all cable, and just before coming on, I lost all water to my house. So I'm just sitting outside in the back on my iPad. So if I go out, it's because the cellular went out in town. So I'm sitting this, and I'm really looking forward to tonight. We've done this. Well, hey, you usually ask the question, Rob.
I know.
I know you didn't. What number are we on? Like,
what number are we?
What number, Phil?
Does anybody know?
24.
24?
Oh.
Did you say 24?
Oh, wait, that's sound bites. Sorry.
Yeah. We've done more anyway. It's a great honor tonight to have two really good friends of all of us really on here, and we'll get to see them if nothing else on the internet here through the Zoom. But with Dr. O'Donnell and Amir, they've been two longtime friends of mine, and I'm really looking forward tonight. And I know Rob, you know them, and Ash, but it's going to be fun just talking with them tonight.
All right, nice. Thanks, Mike. So Phil, what did you say? 34?
34, 35.
Ash, do you remember?
Oh.
Nobody remember for the guys in Melbourne.
For the guys in Melbourne, I got it. I know it is. It's 37.
Every month we can't remember.
37.
37.
I can't remember.
Barb was close. She was really close. All right, let's get started, guys. Let's introduce our two guests. Our first guest, Dr. John O'Donnell, is Australian orthopedic surgeon specializing in hip surgery. He trained in Australia and undertook postgraduate training in UK and Austria, then returned to work in Melbourne, where he's at presently. He started performing hip arthroscopy in 1992 and has now performed more than 12,000 arthroscopic hip procedures. He's a member of the original founding group of ISHA, and we found out before we started that he's only missed one ISHA meeting. He was president of ISHA at one time. During his time as president, the physiotherapy section of ISHA was formed, which we're thankful for. And he's also the founding president of the Hip Joint Preservation Society of Australia. Thank you, John, for joining us tonight.
I want to add one thing, and he's a great guy. He's a great guy.
I don't think there was any question at all about that.
I'll throw that on there formally.
All right, our next guest.
We were warned that this would be a very informal session, but I had no idea how informal it was going to be. Thank you very much.
Totally informal. Our next guest is Amir Takla. Professor Takla was born in Alexandria and educated in Melbourne, Australia. He completed his physiotherapy training at the University of Melbourne in 1997. After completing 12 months of clinical practice, he was successfully enrolled in a Master's of Physical Therapy program at the University of Melbourne. The clinical master's program focused on advanced clinical reasoning, problem-based learning, and manipulative techniques. He joined the Ivanhoe Sports and Physiotherapy Clinic as principal physiotherapist. In 2007, he was successfully recognized as a sports and exercise physiotherapist by the Australian Physiotherapy Association. Thank you both for joining us tonight. This should be a great, just a fantastic topic.
I also add to his, you didn't have this, Rob, on your bio, with Amir being one of the I would say from a clinician point of view, one of the leaders in professional tennis and has spent a great deal of time in professional tennis, traveling the world, really. They say that, and it may come up in some of the stories tonight with Amir, but he's been to all the big events and doing all that, but he's our resident tennis expert also.
Awesome. That's
I'm happy to be
fantastic.
back. I'm happy to be back.
Do what? What'd you say, Amir?
I'm happy to be back in Melbourne. That's it. No more error. I'm done.
Until January. In January, you
Yeah.
get busy again, you guys.
January, that's it. Or New York and US Open. That's the only time I'll come and visit.
There you go.
Well, so our topic tonight is an article by Griffin et al. Hip arthroscopy versus best conservative care for the treatment of FAI syndrome, the fashion study, a multi-center randomized controlled trial. And it's the major aim of the study was to compare the clinical effectiveness of hip arthroscopy with what they called best conservative care. So, Amir, do you mind just starting out, giving us kind of a brief synopsis of the study and maybe what it told us? Kind of an overview.
It was actually tricky. I actually did a few slides and I thought, no, this is supposed to be quite informal. I won't do slides. So I'm going to try to make it as simple and as quick as possible. So they set out, it was at the time when there wasn't a lot of evidence on surgery versus physio versus surgery. So Griffin et al. Set out to put this all together and run it through an RCT. And what they did is they set up the study. It's a multi-center pragmatic parallel arm randomized control. It was through the NHS in the UK. And basically they recruited something like 600 patients, or 600 patients were identified as appropriate, but they only took in about 348 patients, over 16 years old, clinical radiographs. For them to have FAIS, as in the syndrome, they had to have clinical signs, symptoms, and radiology as per the Warwick consensus. So they picked those patients. Some went through hip arthroscopy and some went through conservative care. And the conservative care arm was classified as the personalized hip therapy, PHD arm. Now, before people jump up and down going, okay, what was in the physio? What did it include? They actually set out, because they were aware of this question, so they set out and set up a Delphi study. They went through all the physios around the world. They picked a few from the UK, a few from the US, a few from Australia. And they did a Delphi program, looked at what everybody did, what they found was valuable. And then they set up the personalized hip treatment program. So patients that had randomized to hip surgery, they had hip arthroscopic surgery in the 23 centers. The surgery was also then reviewed by an experienced panel to make sure that the surgery was actually appropriate and done well. And then the other group had physio. Now, the physio group had anywhere between 8 to 12 sessions, between 12 to 26 weeks. They were supervised by a trained physio. It couldn't be anybody. And the patients that had the personalized hip therapy, those physiotherapists were different to the ones that did the post-op physio to make sure there's no cross-contamination. So they thought of everything quite well. I think it was done quite well. They had education, they have activity modification, they had a structured exercise program, there was advice about lifestyle, and they gave them as much backup / supervision as possible. So there's the two arms, the surgical and the personalized hip therapy. Outcome measures, the IHOT 33 was there's the dogs.
There's you go.
There's my cow.
Let the dogs out. Yep. Had secondary outcomes as well. They looked at return to sport, the EQ5D, they had pain scores, they had complication rates, and they also looked at cost effectiveness. And the outcomes at about 12 months were the hip arthroscopy group had a greater improvement in outcomes. The personalized hip therapy group also had an improvement of outcomes, but just not as much as the surgical. The between group difference was significant. It was 6.4 points, which was above the clinically meaningful different threshold. Complications, the hip arthroscopy group had a 5% complication rate, mostly minor. The personalized hip therapy group had no complications. This was an interesting point in the results. Crossover, 30 patients crossed over from physio to surgery. Cost, HA obviously, surgical intervention obviously costs more than physio, and that's what they reported. Modest improvement in the HA group in the quality adjusted life score. Cost effectiveness, uncertain at that point. What else was there? Now, conclusions, hip arthroscopy is more effective. This is what they came up with. Hip arthroscopy is more effective than personalized hip therapy at 12 months. The clinical benefit of surgery is statistically and clinically significant. The cost effectiveness remains uncertain, as not all patients benefited equally. And both groups did well. It's just the surgery did more well. So we need to be aware of those things. And that's pretty much it as a summary.
Yeah, no, that was great. That was fantastic. Well, I think we'll get into a lot of these details as we start going through. First of all, what I would like, Phil, do you mind? So this, Amir said it's multi-center, pragmatic, assessor-blinded, randomized controlled trial, 23 different health service hospitals. Can you just talk briefly maybe about the difficulty of performing a study of this magnitude? I mean, like, think about it. You're getting data from 23 different hospitals and all the stuff that Amir discussed, how they tried to make sure it was a good, high quality study. Can you just like talk to the difficulty of setting up I mean, this is no easy feat.
No, it showed, as Amir said, this is one of the better studies I've ever looked at. And it's no issue that it was published in Lancet, one of the top journals in the world, because it was so well done. The thing that's great about it, as you said, was it's pragmatic. So what does pragmatic mean? It means practical. And so in the research world, you know, we go all the way from bench-based, animal, scientific, well-controlled, high internal validity studies to go, well, how applicable is that in the real world, which is that external validity. So pragmatic studies have a higher external validity than internal validity. And so what we see in these types of studies is this balance I always talk about. Is you have to balance internal and external validity, is how sterile is the study scientifically, and then how practical is the study. And so to your point of having multi-center facilities, this is a very, very difficult study to do. Not only as we know, is just randomized controlled trials difficult to do, but to do it across multiple centers. And Amir gave a tremendous overview of all of the great things that these folks did, all the way from, you know, using the Delphi surveys to identify the consensus of proper treatment, to the fidelity of the interventions, to the cost effectiveness of it. This was just an awesome study. So, but it was very, very difficult, and I give great kudos to those who were involved in it.
Awesome. Thanks, Phil. That's a home run answer. I think that's exactly what I was looking for. Dr. O'Donnell, let's go to you. My guess is that probably the majority or certainly a lot of the people that are listening tonight have an idea of what FAI is, but in case there's some that maybe don't really know the details about what it is, can you quickly just explain the different types of hip morphology that can cause FAI and what type of patients typically you'll see that have these problems?
Sure. So there's all sorts of different ways that hips can impinge. So that one part of a hip can collide with another part of a hip. But the ones that we're talking about here are femoroacetabular impingement, and essentially there are, well, two and a mixture of the two. So one is cam type of impingement, which is a problem with the upper end of the femur, where instead of the femoral head being a globe, it has an area of prominence of bone, typically in the anterosuperior part of the femoral head and neck junction. So there's a prominent piece of bone there, which is referred to as a cam lesion. And so that can then catch on the edge of the acetabulum, typically in flexion and internal rotation, but in other areas as well, and lead to damage at that area at the junction of the labrum and the articular cartilage there. The other type of impingement that's described there is pincer impingement, which is overcoverage of the acetabulum. And that can either be global, so that the whole acetabulum is deep and the walls are relatively prominent and will catch against the femoral neck during movements, or it can be focal overcoverage. So that most commonly is an anterosuperior part where it's just one part of the acetabular wall is relatively prominent. And so the labrum is then at risk of getting caught between the femoral neck and the edge of the acetabulum. But both of them, so all hips will impinge eventually. None of us can send our hip round and round in circles, but this is impingement that occurs during normal activity and leading to excessive impingement and damage to the soft tissue structures. So they're and there can be a mixture of the two. So it's combined impingement. So they're the areas that we're talking about now. It's really common to have this type of morphology, particularly in athletes. So we looked a little while ago at a couple of our major football teams and found that about 70% of the players had some form of FAI, or sorry, had some form of morphology of FAI. These were asymptomatic people. And so it's really common, and even in the general population of maybe 20–25% have some features of this type of morphology. And it really depends a lot on the sort of activity that people do and the extent of the change on whether they develop symptoms and damage or not.
Awesome. Thank you very much. That's a great answer.
Rob,
appreciate it. Yeah, go ahead.
Can
Barbara.
I jump in real
Yeah.
quick and just
Yeah.
support what Phil said? When I'm looking at these patients, my first thought was, well, what if some of them were worse than the other? Their cam and mixed and pincer impingement types are almost exactly the same between the two groups. So it's not like we got one group that's a bunch of cam lesions and one that's a bunch of pincer lesions and one that's more mixed or not mixed. That was really impressive to me, that these two groups, the personalized therapy and the hip arthroscopy, the impingement types were almost equivalent between the two groups. That's pretty cool.
Yeah. Dr. O'Donnell, I want to ask you another question about the I think they talked briefly about open versus arthroscopy, open surgery versus arthroscopic for FAI problems, and obviously there's pros and cons for both, but it seems, is it like other surgeries that it's kind of much heavier weighted toward arthroscopy now than open type surgeries for FAI?
Yes, it is. It started as open surgery. That's how the original FAI surgeries were performed in Switzerland, and they were done as open surgery with the hip being dislocated to do it. And that's still done sometimes. And for the really complex ones and much bigger ones, and particularly if there's other open surgery involved as well, such as a femoral osteotomy or something being done at the same time. So there's still some done that way, and it's certainly a perfectly acceptable way to do it. But the great majority are done arthroscopically now because the surgery is so much less in terms of recovery and complications and so on. But there are times where, in order to perform it well, it's just not possible, or at least it's extremely difficult to do arthroscopically. And so open surgery still has a place.
Yeah. We didn't tell you guys, but we also get questions from our audience. So of the 264 people, I had to look behind my camera here, 264 people that are on. Occasionally they have some questions, and we've got one from Deborah Dorfler, it looks like. And Amir, I guess this may be for you. I guess either one of you, and I read it too, but I don't remember the answers. I don't think they did. Did the arthroscopy group also receive physical therapy after the procedure?
Yes,
Okay,
they did.
so both of them had.
It's a different group of physios than the ones that did the personalized care. So there's no crossover, like no biases.
Yeah, good.
The physios who did the postoperative ones were the ones who normally did it prior to the study. There was no specific structure to it. They each did their own thing, as opposed to the PHT ones where there was a very specific method that was determined and followed and checked on, whereas the others weren't really checked on at all.
Good. And then there's a second question from Deborah. I think I understand what she's asking. I'm going to just read it, so it's not me that's butchering it. If it is, for an adult athlete in their early 60s with positional symptoms related to FAI, would you consider arthroscopy and conservative management from a PT with ortho who is ortho certified and manual therapy trained? They're not So they did, I think what she's saying is they did conservative management with someone who knows what they're doing that failed. They're
Yeah.
not, it says they're not a candidate for a total hip arthroplasty. So would you consider arthroscopy for that person? I'm guessing seems like a pretty simple question, but you would, wouldn't you? If
Yes. There's a general thing around that arthroscopy doesn't work if you're over some specified age, and the one that typically right around is 45. But that's just a very arbitrary thing, and I think it's really not so much age. That's a surrogate for degree of damage in the hip. So arthroscopy doesn't work if you've got an arthritic hip, or at least not very well. Yeah. And so that tends to go with older people, but obviously not always. And the oldest person I've done this type of surgery on was 85. And I did get a lot of blowback on that. And they said, "Well, why didn't I do a total hip on him?" I said, "Well, because he hasn't got arthritis."
Yeah,
and he had no arthritis at all, and he did really, really well. But if you do it on a 30-year-old with a severely arthritic hip, that won't work at all.
Exactly.
So a 60-year-old with a good hip and minimal articular cartilage damage is a perfectly good candidate for it.
Yeah.
There you go. There you go, Deborah. There's your answer. Thanks for writing the question for us. Anybody else that has questions, please feel free to add them, and we'll get to them as we continue. So, Dr. O'Donnell, another question. I know it feels like I'm kind of beating up on you, but I just had multiple questions here, I think, with your name ear tag form to begin with here. So what's your general examination approach when you have a new patient with hip pain that you may think has FAI? And then what's your typical differential for FAI problems?
So is that me?
Yeah.
Sorry,
Yeah,
I beg your
sorry.
I missed a very important first bit of who that was directed. So my examination approach, so it'll typically be a younger person, meaning sort of, well, anything from about mid-teenage through to late 30s. It will be usually someone fairly active, or at least has been very active, particularly through growth years, like teenage, early 20s. If it's an 18-year-old who plays Australian football and has been since he was a child and goes to an academy, then you probably don't even have to think much after that, other than to check that they don't have, some other related condition. So we can come to that one in a sec. In terms of examination, the sort of basic parts of it, we look at the range of movement of the, well, first just check whether they have generalized laxity, because that complicates things a lot, and it's really important to know about. But the great majority don't, because it tends to be a different group who have that. And then we look at the range of movement of their hip, which most likely will have some restriction of movement, and particularly internal rotation at 90 degrees of hip flexion. We look at pain provocation. So that'll be by movements such as flexion, adduction, internal rotation. These tests are not totally specific, but they're pretty good indicators. But there are other things can be positive. It can give you a positive result. So you don't just do those two and say, "Oh, you've got FAI," because there are other things can do it as well. But they will typically be abnormal. So that particularly with a CAM, then internal rotation will often be limited down to, or sometimes zero, but usually less than 10, 15 degrees. And the pain will be provoked. So they're the ones, there's lots of other things we look for. Then there's other differentials. We want to be sure whether they have any type of sort of pubic overload type things, because that can give you very similar pain. So we look at things like squeeze tests and sit-ups and so on, and resisted sit-up to see if they're painful. We look for, I guess we have to look for hernias, although I tend to gloss over those fairly regularly these days because they're pretty unusual. And I still see plenty of people who are sent to me who've already had their hernia repaired, but it didn't do any good. So
no,
that's not quite right. So they're the sort of very basic things. We look at other things as well, but they're the primary. Might look at their spine if that seems appropriate. There's other areas we look at. Do they have gluteal tendon problems? All of those sort of things we look for. But the primary things we're looking for specific to FAI are those two. Sorry, where did I head to from that, or was that?
I think that's pretty good. We can probably. You did mention, I was asking about some other differential things that you you look for, but I think you mentioned some of them. So I think you,
So they're
yeah, that was
predominantly tendinopathies and overload type problems with muscle damage, core muscle injuries, and pubic overload. They're the specific things we look for to exclude, because and they can coexist.
perfect. Thank you. Amir, we'll go to you, and then we have about 3 questions from our audience that we'll get to in just a moment. But Amir and Ashley, you could probably help, and even Mike, I'm guessing. The article describes evidence-based packages for conservative care. What are the main kind of targets that you guys look for when you're treating someone with FAI? What would be in your, because I don't think it really said in theirs, it was kind of vague as to what the evidence-based packages were. If you had an evidence-based package, Amir, for treating FAI, what would be included in it?
That's a tricky question. And I just want to go back one step to the actual paper. When they put the personalized HIT treatment and they put the reference for it, they referenced the papers that they wrote describing it. So it was quite an interesting approach of doing it. So they described it first, and then they referenced it saying, this is what's been published before. So it was
nice.
Anyway, but there wasn't anything else. So it had to start somewhere. So I get that, but I just don't want people going, hold on, it's been referenced. I went, yeah, they referenced their description for it.
Yeah.
It wasn't an RCT or any form of anything else other than we've described it before, here's the paper, and then they referenced it. So that was that. So going back to the original question, what do we look for? Most people that we see come to us because of pain. And because of pain, they have a restriction to some form of quality of life activity or some sport. So my first part of the plan of the treatment is, how do I assist them in helping their pain? And if I can get their pain down, and I'm lucky that I've got Mr. O'Donnell with me, so we can actually, if I need help with injections or medication or extra medical components, I've got access to that. Because if I can help their pain, then we can look at strength, control around the hip, and then building up load. So that's how I would attack it. Pain first. If I can change that, I can get local stability. And if I can get local stability, then I start global loading. So that would be my package of treatment.
Ash, you guys think different? You do different?
Yeah, no, I would agree with Amir. That's my general, I mean, that's a standard PT thing, right?
Yeah.
Pain and inflammation, get motion back,
Mobility.
improve local stability, build on that. So but it sounds easier than it is when it comes to the hip, because there's just so many little random things that come up. And that's why like papers like this are super impressive to me, because I'm like, I don't know how you can even like mentally get anywhere where you can make this something that's reproducible across the board. Because I feel like I see, our clinic, just like Amir, I mean, we see day in and day out, our whole schedule is hip patients. And while the treatments might look similar, they also can look very different amongst
they're all,
the
there's
same
just little
exact
tweaks. Yeah.
diagnosis. And so there's a lot of like, okay, that wasn't working, abort mission, and we're moving this direction. Or this particular person has, a total inability to utilize their deep rotator. So all we're doing is focusing on that. Whereas this person's kind of got it hammered like down, and they actually have just a really weak like adductor hip flexor complex. So we're really focused on that. So it can just look so different patient to patient, but the basic principles always remain the same. And that's where I'll always fall back to, just like I tell my, like the residents who are all on here tonight. Hello, my residents. It always comes back to your impairments. What are your impairments? Work on your impairments, and that's your treatment plan. So
know how to evaluate the impairments
right
initially,
yeah,
and then treat the impairments. It's really what you guys have described is no different if you're treating the hip as if you're treating the elbow or the cervical spine or the shoulder or knee. It's all very, very similar. Okay, let's
hold on, Rob, real quick.
Yeah.
That's the beauty of the pragmatic trial, is that it can be modified based on the clinician's description. And what the pragmatic trial means is that every patient presents differently, and we can't put them in a silo that says they get all of this specific treatment. We could follow an algorithm with best practices, which is what they kind of did here and what Ashley's talking about. But that's what makes this study, when you see pragmatic, you know, you do give up a little bit of the internal validity, but the external validity just shoots up because it says this is how we see patients day to day, and that's why it's a beautiful study.
Great, great. We have looks like 4 questions from the audience here. Dr. O'Donnell, you're first. Does Dr. O'Donnell typically order PT first before surgery for FAI, or does he go right to surgery based on his experience?
Okay. The great majority of people who come to me have already done a period of physiotherapy. I saw one yesterday who'd done 10 years of physiotherapy.
Oh my gosh.
And now felt that was long enough.
Yeah.
So I didn't feel a need to order more physiotherapy for her. But I always ask what that actually meant. So they say, a lot of people say, oh, I've done physiotherapy. And you say, well, you know, what did you actually do? How often did you go? And so on. So if they've, so what I'd need to weigh up is, have they done adequate physiotherapy to really assess that first? And how severe is the problem they have, and what is it that they want to do? So if you have a professional footballer, for example, who's got really big cams, and you know that's going to cause a whole heap of trouble, then they'll have generally done some physio through the club first anyway. But with them, I'll tend to go straight to surgery because they're already doing significant damage, and physiotherapy is no good. It will certainly help them, but it won't stop that damage from progressing pretty quickly. But that's the exception. The vast majority of people, I'll either assess that they have done adequate physiotherapy already, or I will arrange it. And sometimes say to them, what you've done is all fine, but there's some additional things that we really need to try first. And so I'll happily send people off to physiotherapy first. And the majority of people will either go because I've sent them or have already been.
Yeah.
So I think it's an important part of the initial treatment.
Yeah, no doubt, no doubt. Well, thank you. That was Sherry Hopt, I think is maybe how you pronounce her name. Next question from Thomas Henry. Are there any specific or general clinical or imaging findings which you use to guide your choice of recommendation or recommending either surgical or conservative course of treatment? So specific or general clinical or imaging findings to help guide your choice of surgical or conservative course.
Okay. So I guess that's sort of follow on from what I just said. So some of the imaging, particularly if they have really big cams, if they have significant but early cartilage damage on the acetabular edge, I'm not so fussed about labral tears because they can be dealt with early or late. That doesn't really matter. But if they have signs that things are in the process of progressing quite quickly, that will sort of guide me towards surgery. But otherwise, we'll certainly try the conservative way first, because there's a lot of people will respond very well to that. And if they're not very high demand or diminishing demand, then often they'll be satisfied with that and not have surgery at all.
Perfect. Yeah, that probably happens a fair amount, I'm guessing. Yeah.
And Rob, I'd just add, we see a lot of patients off the street in Australia as physios, as primary care practitioners. And I agree with John completely. Like, some patients will come in and say, look, these are the symptoms I've had. I've seen physio for this. I've seen physio here and I've seen physio there. So I'd look at what they've had. I'd also look at the imaging, because we can order imaging in Australia quite comfortably. So if they come in with a cam, they've had some symptoms, they're not improving, they've had 1 or 2 treatments with me, and I can't show a measurable objective change between treatment to treatment, I'll say, listen, we're not showing any form of improvement. I'd like you to get an opinion. Yeah. And then I'd refer to John. Yeah. I don't want to be one of those ones who would see a patient for 3 months and have no outcomes, show no change or improvement. It's not good for them. And Shane No was able to publish that, showing the outcomes of patients that have had physio for 6 months versus ones that had surgery straight away. And I'm very wary of that point.
Yeah, for sure. Yeah, it doesn't look good on you either, I guess, if you've seen them in 6 months.
Especially if I can't show a change.
Yeah, exactly. Okay. Next question. The general George Davies is on tonight, guys. He's on almost every session. Dr. O'Donnell, I believe is for you. You mentioned generalized ligamentous laxity, and that's a different group of people. So George is asking, what role does hip microinstability have in your exam and treatment?
Oh, geez, that's nasty.
Yeah, yeah.
I think that's another 9.
Yeah.
It has a big role because it changes how I approach things quite a bit. So that's usually the first thing I look for. So in someone with this group that we're talking about tonight, FAI, the great majority, if anything, is stiff, not super lax.
Yeah.
But there are a group who are, and that changes it quite a bit. So that I think microinstability is a really important thing to look for, and we do regularly, like always, and it's something we take into account, because sometimes we actually see people where the problem is microinstability, even though they've got little cams, and so we have to be careful because cams are so common, and the great majority of people who have them never know they've got them. So just because it goes up on an X-ray or a scan doesn't mean that's the cause of the problem. And so we certainly have people where we treat their microinstability and don't touch the cam. And I don't do it just because it's there. So yeah, that comes into it. And then the ones who have both, who have microinstability combined with impingement, then we'll take quite serious care to make sure that we close up their capsules and get them really stable at the end of the operation. Because if you just go and deal with the impingement part and don't do that, then you can make the instability worse, and they can deteriorate really quickly after that.
What tests do you do for micro? Oh, I'm sorry, I interrupted you. What tests do you do for microinstability at the hip?
What tests?
Yeah,
The main ones we look for, so there's a whole heap of them, and people have their own favorites, but the ones I look for, so I start off just with a Baton score, or Baton score, depending on how you want to pronounce it, which is an indicator. It's non-specific, it's developed for something totally different, but it's helpful and it's quick. We look at range of movement of the hip, so they tend to have big increased range of both internal and external rotation, and we look for apprehension tests. So for anterior apprehension of the hip, and like you might do for a shoulder, and try and sort of push them into that type of position and see if it's painful or feels unstable. There's a whole lot of others, and we look for a dial test for sort of increased range of external rotation just at rest. They're the ones I look for straight off, and then we might do others on top of that.
Hey, John, this is Mike, but can you maybe explain, I think you mentioned this, but for the audience on there, because you're talking about tonight we have FAI, which is largely a problem with mobility or a lack thereof, we get it. And this, as George is bringing up the microinstability, can you maybe elaborate on how it, when you said it can appear together, and meaning, and I think what we're getting at, or what maybe he was asking is, if you get that cam coming in on that superior aspect, it can lever out the opposite side of the joint and create a capsular laxity, I guess, there. And if that's the case, do you see that? And when you talk about dealing with the capsule and doing some closure, is that where you would come in on that opposite side to tighten the capsule up?
I don't do the posterior capsule very often, or in fact rarely. And because the way it all works anyway is if you tighten at the front, because it's sort of a global structure, it tends to tighten right around anyway. So you don't generally have to very specifically do the posterior part, but we make sure that we're not increasing, we're not leaving bits open. And particularly because the bit that we open to get into the hip is at the front. Right. And so that's the iliofemoral ligament at the front, which is obviously a really, really important ligament. And if you go and slice right across it and I don't do that in the first place, but plenty of people do because that's the way they get into here. So for that, it's really important to repair that, because it'll heal to a degree after, if you do nothing, but it'll heal a lot more lax than it started out. And it was already lax. And so if you do that, then you're just adding to that problem. So if anything, we try to tighten it a little bit when we close it. Well, not try to, we do. And so that will tend to improve that stability situation of the hip.
Yep.
So does that answer what you're asking on?
Yeah, that's part of it. I was thinking that some people can develop, like you were saying, they can have microinstability. They can have impingement, a big cam, but their symptoms may be related to the laxity being created because of that on the opposite side, as that femoral head kind of gets levered out of the acetabulum a little bit, which could even lead to some of your other work that you've done, which again wasn't even tonight's topic, but with ligamentum teres, potentially it could be issue with that as well. But I was just wondering that whole spectrum that you see along those lines that leads into that, from a typical mobility restriction with FAI to potentially having some micro instability with it.
No, I agree with you. And we do see that. And so they lever at the front and lever out the back,
Right.
if that makes sense.
Yeah.
And that poses the mechanisms where they do tear their leg teres.
Yeah.
And because you see that in combination with FAI, diminished range of movement, how come they're tearing an internal ligament? And I think it's because of that levering. I think that's precisely the case. If that's happening, then I'm sure the posterior capsule is the same.
Right.
Yeah.
I agree.
We definitely see that with some of the tennis players and the gymnasts. But once they have the tightening up procedure, we find that because their pain drops and because they're stable, their physio recovery is just almost smooth sailing.
Quicker. Yeah.
And that's what I've learned from you, Amir. It's kind of was a loaded question bringing it in, because from my angle of it, and I know Ashley addressed it when we had our rehab question, but what I've learned the most in this process from you and John is your whole deep rotator program that you guys sort of perfected and progressions through that. Because I find, particularly in that gymnast / well, in your case, tennis, but the different things, to me, I think that's the vital part of that rehab process, that we try to keep that femoral head centralized, if at all possible. And in my experience, it's the deep rotators are the key to that centralization process. And again, people oftentimes think that, hey, wait a second, we're talking about these small little muscles like a gemellus or an obturator internus, something. How can that possibly be? But, you know, they functionally work as a unit. They're one big unit. And the reality of it is, if you take the cross-sectional area of just those deep rotators, you know, you're talking about a cross-sectional area of the gluteus minimus. And if you throw in piriformis and quadratus femoris, I mean, you got quite a big force producer right there that plays a big role in that centralization.
Yeah.
Did I say it right, Amir? Because you taught me all that.
No, it's perfect. Spot on. I couldn't have said it any better. It was brilliant. It was brilliant.
Yeah, Mike just saved you, Amir.
Yeah. No, he taught me.
Completely.
All right, we got another question from my man Lance Gill on tonight.
Oh, Titleist is in the house.
I figured, I figured he would be recuperating from his. Wasn't he just on vacation?
He was in the Greek Isles.
Yeah. Was that vacation or was that work?
He doesn't work. It had to be.
So then it was vacation. Yeah, they must have been vacation.
He works in golf. It had to be.
Lance asked Amir, I guess you can answer this one. How much postural analysis above or below the hip joint is in your standard eval? And I guess could you tell us kind of what you look at in regard to posture above the hip and or below the hip in the lower extremity?
Brilliant. Hi, Lance. Haven't seen you for a little while, mate. Good to hear from you. Definitely look at it. Very loaded question, but sure. Definitely look at pelvic position, whether it be anterior pelvic tilt or posterior pelvic tilt, position of lumbar spine, position of the knee, especially when you're looking at your population of golfers. We do exactly the same with our tennis players with regards to the position for serve, forehand, backhand, and drop shots, the angles and the setup. And the difference with the implication for it is whether I'm closing the front of the hip or opening the front of the hip, and depending on the load, especially when you're looking at golf and tennis, we're looking at axial rotation. So when I'm looking at axial rotation, whether it be on the upward phase or the downward phase, depending on the sport, the pelvic position will dictate loading around the femoral head neck junction, as well as the capsule. And they're the things I need to protect. So if I've actually got somebody with considerable anterior pelvic tilt and they're trying to get maximum force or torsion for a forehand, that's not going to be great for the hip joint, and let alone in the follow through the other side. So going back to your question, the posture in every direction, sagittal, coronal, planes, I need to actually be able to assess that. And without making it too complicated for our participants, pelvic position, knee position, foot and ankle, and then torso or trunk rotation on that pelvis in summary.
And you're doing, and Amir, so you're doing like, are you doing like a deep dive into all of those, or just like a quick screen of those? I mean, you're checking everything. You're looking at motion, strength, stability of foot, ankle, knee, trunk, and everything, or just a quick kind of screen of it all?
I'll do it as a quick test for general public initially to see if I can pick anything. But with a athletic population, then I'll look at every angle and I'll record them and then analyze it later to make sure I'm not missing anything. because with those guys, force transmission, especially with serve speed, critical. Just the same as what Lance would look at for that drive range at the start. The swing phase is so critical to get the drive distance on the golf ball. Same thing. Quick test first.
Yeah.
If I need to go deeper, then I will.
Yeah, gotcha. There's another question here from what says anonymous attendee, but at the bottom it says Tracy. This I think is a really good one. Tracy's asking here. She says it's a loaded question on the psychosocial part of care. How do you address? And she's got a specific example of ice hockey players. She said they're similar to marathon runners who won't stop playing with treatment so they're getting treatment while they continue to play. So they're having symptoms. Amir, you have to see this all the time in tennis, right?
Mm.
They don't want to stop. They won't stop playing. They have the problem. You're trying to treat it, but they won't stop. If they've been playing since a kid hip impingement with, what is it? I can't read this.
You need help reading.
Yeah, maybe. Can you read it? What is she saying there? I didn't get to
Acceleration starts early. Basically, chicken or the egg. Did they have it, or did hockey cause it? They continue to adulthood. She really just is asking thoughts on ice hockey players in general.
Which is big in Australia.
It could relate to anybody, though, right? It could relate.
Yeah,
to,
this is athletes in general. To be honest.
Yeah.
It's a hard one, because this is usually, if we're looking at professional population, this is how they make their income. This is their livelihood. So just that's their job. That's how they survive. So the tricky part with those guys is I'll always, if I've got them, we assess them and say, listen, if it's something, you've got a large cam, you've got early signs of cartilage pathology, you potentially have bone marrow edema, you're impinging, the structure of your hip joint is not stable anymore. Your negative seal or your suction seal from your labrum is damaged. You're starting to get cartilage symptoms. We're going down now a slippery slope. So the choices are, we can manage your symptoms while you go up and down with irritations and exacerbations, or you can go and have a surgical opinion to see if we can prolong the life of your hip. And I'd explain both avenues. This is the role of physiotherapy. This is the evidence for physiotherapy at the moment versus the evidence for hip arthroscopic symptom. So that way they've got informed consent, they know where we're going. And the tricky part with them will be is, do they forego on 6 to 12 weeks, have the surgery and go through a structured rehab program and get back? Or continue as they are now with the performance that they've got? So rather than telling them, I don't want you to play, I look at it and go, you're a performance athlete. Where do you want your performance to be, and for how long? Do you want a longer career with appropriate performance? I think this is a better option for you, versus we can manage you up and down until your performance gets so bad. And this is where the complication comes in with, whether it be ice hockey or tennis or even gymnastics for that matter. If I try to swing it from a point of view, not just pain, from a performance point of view and longevity, then they pay a bit more attention. Rather than don't play, you're going to fall apart. Oh no, I'm going to play because such and such did. Andy Murray, Leighton Hewitt did. But if you go and go, well, when they had their repair, they were able to last another 6 or 7 years. Here's their number, talk to them. And because it's a small circuit in the world tennis, they'll ring each other and go, oh, actually, he was able to get back and play 5 sets in 12 weeks or 13 weeks. So to answer your question, I try to put it from a point of view of performance, rather than you can't play, you're going to do bad, you're going to hurt yourself more, If I change and say, well, your performance actually can improve and you can perform for longer period in your life, then I find that win them over a little bit better.
A little better buy-in for sure.
Yeah.
Dr. O'Donnell, another anonymous attendee asked, how often is there regrowth or recurrence of either the cam or pincer after you do surgery? So is it very, very often once you do surgery, does that ever come back?
I used to say it doesn't come back, and I think that's very largely true, because it's something that occurs during growth. And so if you just remove it, it's finished growing. There's no stimulus for it to grow again. If they're becoming degenerate, then they can get osteophytes and they get other forms of spurring, and that certainly can occur. But the cams don't come back, with very rare exceptions. Even if you do it in kids who still have open growth plates, they don't come back.
Good.
You expect that might, but I haven't actually. I've seen one where I thought maybe that's what had happened, but that's only one. Maybe I'm blind.
Yeah, out of a bunch. Yeah. Another question. We got, thanks everybody for sending these questions. And we got just like a bunch of fantastic questions. Keelan and Seki, I think you guys know Keelan. You both know Keelan, I think. Do you find any defined role for orthobiologics in non-operative or post-operative treatment of FAI or chondrolabral injury? So what do you, what's your role with orthobiologics, or what's your thought process?
Do I? At this stage, I find them extremely limited. That if we're talking things like PRP or stem cells, or I'm not sure if he has particular ones in mind, especially with professional sports people. They've often tried them all first before they see me anyway. But I think the role at this stage is extremely limited. But I think in terms of trying to get cartilage recovery, there's sort of an increasing role, but it's still pretty early days in terms of actually achieving that. But we do use them, but in a very limited way.
When you were talking about the deep, I guess maybe Mike mentioned your deep rotator program. Kimberly Overgard is asking, what are the components and exercises of your deep rotator program that was discussed?
Okay. Thank you for the question, Kim. When I first, just a little disclaimer, when I first started working in hip, or the reason I started working in hip is I hurt my hip 23 years ago. And I was at the Olympic program then. I was one of the physios for the gymnastics program in Australia. And I had like 5 or 6 different diagnoses. And finally, I researched, and I had a couple of, actually 3 choices: to come across to the US to see Dr. Thomas Bird, to see Mr. John O'Donnell in Australia, or to see Ricky Villa in the UK. So I went to my GP and I said, look, I'd like to see Mr. O'Donnell. And I still quote, and John laughs at this every time I say it. My GP was like, oh no, I don't want you to just go to him. He's a cowboy. God knows what he'll do to you. Anyway, I went.
Anyone less like a cowboy than me is hard to imagine.
So anyway, I went to see John, pulls up my x-rays. This is what a CAM is, and this is FAI. And I'm like, I've never even heard of this. So anyway, John diagnosed that I had the surgery and I was back to normal. And then John patted me on the back and said, right, now you can figure out how to rehab this thing. I've figured out, I'm doing the surgery, but I don't know what to do with rehab. So anyway, I went back to anatomy, did more dissection. And at the time, I was basically a shoulder physio. I didn't really do much with hip. So then I looked at the hip, looked at the shoulder, and went, well, maybe these rotator cuff that we have in the shoulder might be something similar in the hip. I didn't know how to assess it. I didn't know how to find it. I couldn't figure out how to palpate it. So I went to radiology and said, right, can you use a real-time ultrasound and show me what muscles I can see? So all I could see was basically QF. Well, that's all I could see with my eyes and feel with my hand. So then I looked at the vector forces. Then I played around with some exercises and I thought, well, hold on. If we do rotator cuff exercises from isometric to concentric to eccentric to different angles to stabilize the humeral head, could I do something similar in the hip? So then what I went through then, Kim, is I tested it on myself and I was back running 4 weeks post-surgery, which at the time was really quite wild. And I remember John looking at me going, really? You can run? Yeah. And I was running about 4 kilometers, so 2.5 miles every second day, pain-free. So then John said, well, why don't we test this a little bit more and then maybe try to run a trial to see if it actually does make a difference. So I tested it out for 4 years with different patients. We had favorable outcomes, and then we put together the FAIR trial and we published that in 2016. So what we designed is just very similar to what we do in the shoulder. I decided to do the same. Teach people how to stabilize the femoral head and the acetabulum in the prone position. So it's a simple, non-weight bearing position the patient can feel with their hand. I added external rotation with gentle resistance. They were able to stabilize. And then I went to 4-point kneeling, then added internal and external rotation. And then I added more force to add the gluteal muscles on top, and then weight bearing. So in the FAIR trial, and it's open access, I've actually got the protocol, the exercises, the dosage, and the angles. There's nothing to hide. At least this way, if everybody could see it, I get more feedback, whether it's working or not working, whether people are getting better or not getting better. And just recently, the British Hip Society has actually published that to be used in all over NHS as a protocol that people can add, modify, change, but at least it sets out a template. And I wanted to do the RCT on it so that when I speak to our orthopedic specialists and say, oh, really, refer to physio, we do make a difference based on what? And I thought, well, here you are. Here's the
Yeah.
publication protocol.
Nice.
We tested it on randomized control patients. And
Mhm.
before people bring it up, oh, you had outcomes, but at 6 months, they were the same. Yes, at 6 months, patients actually got the same, but the people that had the physio protocol, the Takla O'Donnell protocol, they were back up and running by 12 weeks, significantly faster than people that didn't. So I can say to patients, if you want to be bouncing back quicker, here's a protocol that you can utilize. And of course, change it and modify it as you see fit. So if you want it, Kim, it's out there, open access.
I just put the link in the chat.
Oh, great. Thanks, Ash. All right. Victoria Torres is asking, does the presence of significant femoral anteversion alter your arthroscopic approach to cam impingement? Is femoral version assessment included in your evaluation process for those patients?
Yes. Yeah, that's a very simple one.
A simple, very simple
This is
question.
really
Answer
important.
yes.
And, because, well, excessive antiversion tends to make them more unstable, and retroversion tends to make them impinge more. So yes, it's important, and you may find that sort of standard things that you might do just don't work if they have increased version or in either direction, or sort of call it malversion for want of a better word. And so femoral rotation osteotomies are a part of the treatment. You know, there are some people who do it a lot and some people who do it very infrequently, and I'm more in the second group because I think it's not quite such a benign procedure as people make out. And it does have other consequences to the knee and other parts of your leg. But it's certainly part of it. And so if we're talking sort of 30 degrees plus antiversion, then yes, that plays a major role. And if you have a significant retroversion, that does too. Things in the middle, it's a bit more grey.
Yeah.
So if there's some suggestion of that, then we'll, on examination, then we'll get CT scans done and include the knee and the hip and look for and measure as accurately as we can what the femoral neck version is. But yeah, it's really important.
Perfect. Well, guys, we have like 1 minute left, and like usual, we have 12. Unfortunately, we have 12 unanswered questions, and we really only all we did was like scratch. Happens every time, guys. We barely scratched the surface of the article, and then we get great questions, and then like Dr. O'Donnell, you sent me the email, said I'm sure there's going to be some side questions and things like that. That happens every time. That happened tonight, but I think it's, to be honest with you, I think this is the best. I mean, we use the paper as kind of a guide, but the questions that all the participants send are always just fantastic, and it's no different tonight. And unfortunately we're leaving a ton of them on the table.
We're gonna have to invite them back, Rob. They're gonna have to come
get
back.
you back again.
Absolutely.
Yeah. We'll get you on for 2026.
Yeah.
Well, thank you guys very much for coming. We really appreciate it. It's been a great evening, great journal club. We had a ton of people on, so we really want to thank you so much. And I guess, are you guys going to Japan?
Yeah, indeed. Yeah, we'll be there.
Some of us will see you in Japan, I think.
You're in Japan.
Excellent.
Yeah.
We will look forward to that.
Thanks so much. Okay, well,
Thank
we
you
got
very
another
much.
great one coming in July. Be on the lookout. We'll start sending emails here in the next less than a week. So replay will go up very soon. Thanks, everyone.
Thanks for having us.
Thank you. Have a good tomorrow.
Have a great day, guys.
Hey, guys.